Good afternoon, everyone. You are tuned in with us here at Safe Passage for Children of Minnesota's free webinar, and this is on the Minnesota Coalition of Family Home Visiting with Laura LaCroix-Dalluhn. My name is Stephanie McCorkle, and I am the Operations Manager and Volunteer Coordinator here at Safe Passage for Children. And our mission here at Safe Passage for Children is to strengthen the Minnesota child welfare system so that children are safe and can reach their full potential. One of the ways we achieve this mission is by offering these bi-monthly webinars, which are currently turned into. If you'd like to find out more about our webinars and also all the other things that we're up to, please visit our website. It's at safepassageforchildren.org, and there you can sign up for our mailing list and sign up for our blog posts, as well as check out our new podcasts. You can also follow us on Facebook, Instagram, Twitter, LinkedIn, and YouTube. So just a couple of reminders about this webinar. This webinar is being recorded. Please mute your microphone or microphones, however you are tuned in with us, until the question and answer session that happens later. We invite you to turn your camera on so we can see you unless you anticipate distractions, or then go ahead and feel free to turn off your camera if you wish. After the presentation, we'll have plenty of time for questions and answers. If you're welcome to ask questions, just remember to unmute yourself. You can also use the chat feature in Zoom to type in your questions, and this is located at the bottom of your Zoom window on your screen. If you have any questions about any of those things that I just talked about, feel free to shoot me a message in the chat nodule or send me an email, and I'm at stephanie@safepassageforchildren.org. And now I'll go ahead and turn it over to our Executive Director, Rich Gurman.
Thanks, Stephanie. So I will introduce our guest presenter, Laura LaCroix-Dalluhn, in just a moment, but let me just make one announcement, which I do at this point, which is about the next webinar, which, as many of you know, we have every 2 weeks. And coming up in 2 weeks is a presentation on the federal Families First Act, which is generally considered to be the most important piece of legislation around child protection and foster care in 25, 30 years. And it is really complicated. I won't pretend to understand much of it. So we have Kirsten Anderson from Aspire, which is the trade association that represents many organizations in the child welfare field, who is going to come and explain it all to us. So I'm looking forward to that because I really need to understand this bill, and it's really complicated. So please tune in 2 weeks to hear all about the Federal Families First Act. So I want to introduce our colleague, Laura LaCroix-Dalluhn. She is the principal and CEO of her own consulting firm, and also the coordinator of the Minnesota Coalition for Family Home Visiting. And the term coordinator doesn't really do her justice. She has really been the leadership person in pulling together a large coalition that has worked very effectively to advance the cause of family home visiting. And as Laura, I think, will say, so I'm not going to say all the things that I would like to cover, but she's probably going to talk about the fact that family home visiting is one of the few services that really has been shown by research to have an impact on child maltreatment in terms of preventing child maltreatment. So obviously the thing we all love to see is when children don't get maltreated in the first place. And this, along with early learning scholarships, are really the only two services that have an impact on preventing child abuse in the first place. So with that, Laura, let me have you take it away and tell us all about you.
Great. Well, thank you so much for inviting me to be with you today. I'm super excited to share a little bit about the coalition and our work. I'm just going to pull this up for your viewing pleasure. So a little bit about myself. As Rich said, I am the principal and CEO of LaCroix-Dalluhn Consulting, and we provide support to a number of coalitions that have interrelated missions. The Minnesota Coalition for Family Home Visiting, you can see the bottom of the slide. Formerly the Minnesota Coalition for Targeted Home Visiting. We're in the process of naming and renaming and branding to make it easier for people to know who we are and what we're about. We also support the Prenatal to 3 Coalition. It's a statewide coalition focused on maternal and child health and early learning opportunities. And then we support the Hennepin County Children's Mental Health Collaborative, and then a few others. So I just want to make sure that you kind of see the bigger, broader picture. The Minnesota Coalition for Family Home Visiting is a coalition of nonprofit organizations, local public health, educational institutions, and human service agencies that provide family home visiting and as services. And what we do is we focus on 2 main goals. We really focus on building quality or sustaining quality services to families, and increasing access. And the access piece is what brings us to the public policy side of the work, which is a big focus of what we're here to talk about today. But I wanted to share a little bit about home visiting, what we mean by that, what's kind of the focus, and how it relates to child maltreatment. There are many different ways of offering home visiting services. Some programs provide it through a focus on parent education in the home. In Minnesota, we see that happening a lot with ECFE programs. We have programs like Early Head Start that are focused, the home-focused, homebound ECFE programs are focused on child development in the home as well. And then we have public health-focused home visiting programs. In the state of Minnesota, the majority of them are evidence-based programs, and that is what Rich was mentioning around proven methods to reducing child maltreatment. We do have other home visiting programs that show progress in that, but it's really the evidence-based programs that we know have made the biggest impact because they've proven repeatedly these positive impacts for families. What I would say is most important about home visiting, if you're not familiar with it, I assume based on your role and connection with Safe Passage that you know that babies and young children thrive when they're in caring and stimulating environments. And in home visiting, much of what we are doing is focusing on that parent-child interaction. And it's really when developmentally early on in life that a child has stress because they are hungry, or a child is stressed because their diaper is wet, or that they are scared or frightened of something. It's that interaction with a caring adult that they are responding to that stress, whatever it is. And that they know that if I'm stressed and I communicate my stress to you, that you can build that trusting relationship. Those foundational moments and times and minutes in our life really, really set us up for all the other positive development we do in life. If we don't meet those really basic foundational interactive needs, you can work to repair them because we still develop, we still grow, or we still become people, but we have to go back and do some repair. And that's it's not that it's not possible, but I will say that it's a lot easier when we attend to that interaction up front and in a really intentional way. So a lot of the evidence-based programs, home visiting programs, are really focused on that parent-child interaction because we know that's what builds healthy development. That's what helps a child reach those important developmental benchmarks. So I'll just leave it at that. Is it okay if I ask for questions along the way, or just say, please jump in if you have questions, or throw them in the chat?
Generally, we hold questions till the end of your presentation, but people can put questions in chat.
Okay, perfect.
And then we have them queued up for you.
Okay, and I'm happy to share some additional resources if you'd like to learn more about home visiting programs and where you can find them. Like I said, I'll put that in the chat, or I'll send that out so for those of you participating can learn more about it. What I wanted to do is take some time today to share some of the work we've been doing in-home visiting to through the coalition to help increase access to home visiting services, as well as helping meet the increased needs of the families that we're serving. So the Home Visiting Coalition, as I said, we focus on quality and we focus on increased access. What we have been working toward in the last several years, and it passed in session this year and in special session, is we had been working with a number of community partners to increase state funding for family home visiting. And we were successful back in 2017, getting $12 million in state funds. And then that increased in 2019 up to $33 million for the biennium. We wanted to make funding available for both evidence-based programs and evidence-informed programs. The evidence-based programs are what we talked about at the beginning that show evidence of having prevented maltreatment, but the evidence-informed programs we thought are equally as important because that's how you bring innovation. That's how you address challenges and needs within a community. And so we were successful this session in changing the language so that up to 25% of the funds could be used for evidence-informed or best practices. And that will allow the state some additional flexibility in funding programs that are based on science, that show outcomes, but that we're really trying to either hit a specific outcome, whether it's child maltreatment or parent-child attachment, healthy child development, school readiness. There's a number of different benchmarks that we try to meet with home visiting. It will allow us to fund some of these more best practice programs and really target some resources there and then bring that back to the greater field. So there's a new statute, the Family Home Visiting for Pregnant women and families with young children, formerly the evidence-based home visiting program. So that will be in statute. That was included in the skinny HHS bill that passed in May. And then the legislature increased funding for home visiting by $4.5 million over the next 3 years. This is a one-time increase using some of the federal emergency funds at $1.5 million per year. So in order to get some of these evidence-informed and promising practice programs up, they wanted to put some additional resources in so that we could evaluate some of the successes that are happening locally. We also were able to help secure work with our partners who operate Nurse Family Partnership. That's one of the kind of the gold standard public health focused home visiting programs. There was in the governor's bill, when it was first introduced back in January, they were proposing to reduce it by 800,000 over the biennium. And it was more based on, the reason was because how the funding was rolled out, there wasn't enough flexibility in how it could be spent. So rather than making those cuts, we were able to work with the legislature, work with the department to make the resources more flexible in how they get used and how they present them so that communities could better access these resources. All right, let me move ahead. In addition, as I mentioned, the Home Visiting Coalition is starting to really focus some of our time and energy on either specific populations that access family home visiting and or the other issues that impact the families that we serve through family home visiting. So one of the policies that you may have heard that passed this session and again directly impact child welfare rates is the Healthy Start Act. And this is exciting bipartisan legislation that passed during session. The policy passed, and then the funding was included in the public safety bill. This will allow women who are incarcerated in prison, state prison, so not the county jails, but the state prison. So it's going to impact about 200 families. It will allow you, if you are pregnant or parenting within the first 12 months, to be moved to a community alternative setting. So you would no longer need to be in the state prison, but you could be moved to a community alternative setting and be in relationship with your child. This is a huge change. So we are very excited to see this movement. Previously, within the last few years, they have also made changes where they were still shackling women during the birthing process. So this was some recent changes. And currently women have up to 48 hours with their children before they are moved. So they give birth and then they are removed 48 hours later. We know approximately 81 to 87% of parents, whether it's the mother or the father of that child, will return home from prison or jail time, or their experience with the justice system, to go back to being a parent at some point in time. That's a really high percentage. And what we know, what happens in those first few years of life, if we can start to build a trusting relationship between the child and the mother, it will help change the trajectory for that child and for that family. So we are very excited about this change, and we hope to take some of the lessons learned and even think about how we might implement that in county jails. So that's a very exciting thing for families. Another change that we were excited to see pass this year is an extension for MA coverage postpartum up to 12 months. Currently, postpartum coverage is stops at about 60 days. So this will extend it to 12 months. This will have a really big impact. There's lots of research to show it has a big impact on mom's health, which ultimately then has a impact on the child's health. We see a lot of women who experience postpartum depression or who are still trying to manage substance use, chemical use. If they're not getting the care they need, many times because of insurance purposes, we believe this will make a important change for them in accessing care for themselves and for their children, and ultimately help reduce some child maltreatment issues. Telehealth was also, telehealth was also services were extended. So we did pass a big telehealth bill in Minnesota. This is specifically targeting MA covered services. So this is for mental health, physical health services. If a family needs to access them, they can through telehealth, and it also includes telephone. This is an important extension that we think will help serve a lot of families. In greater Minnesota, we know access is a huge issue. We talk about that all the time for mental health services, for chemical health services, all of which lead our issues if we're trying to address child maltreatment. And so a provider will be able to get reimbursed at the same rate that they would if they're doing an in-person visit. So we think this is an important step forward in helping serve many of our families. I'm also happy to report we have some new pregnancy and lactating protections in our jobs bill this year. What they did is they made it clear that all employers with 15 or more employees have to make it, they have to allow a woman to take a rest during her pregnancy, at least 15 minutes. They do not, you can no longer require them to bring forward a doctor notice saying that they have to sit or be off their feet. This is common sense that during the pregnancy, it's really difficult on your body. So they changed that so that employers do have to accommodate within reason changes related to pregnancy and to provide spaces and time, paid time for lactating purposes. So if you are pumping in the workforce, this allows you to do that, and we have additional protections there. It is amazing to me how many of the families that we work with through home visiting who don't know their rights. So I'm excited. I can also share there's been some new promotions around knowing your rights around pregnancy protections, pregnancy leave, lactating protections, all of these are important with young families and serve the families that we're working with. Another important policy change that happened impacting young families, both through the pregnancy and early on, is the substance abuse reporting requirements. So they have now changed the substance abuse reporting requirements to try to decriminalize substance use and abuse. If you are actively working on your substance use and you are talking about your actions and your work to try to address those, you're no longer, as a mandated reporter, required to report on these concerns. There does, in my opinion, looking at the law, it does leave some interpretation, but the intent is to try to decriminalize substance use and really try to make space for that caring relationship to try to help moms during the pregnancy and early on in child in the parenting. Another important legislative change, policy change that does have some funding as well, is the Dignity in Pregnancy and Childbirth Act to address health inequities and implicit bias. We see in Minnesota that Black and Indigenous women have poorer health outcomes, maternal health outcomes, and childbirth and child health outcomes, regardless of income, regardless of education. We know that this is really truly about implicit bias. It has a really long-lasting impact on one's health. We know about epigenetics, how it gets into our, how racism impacts our bodies, how it changes our physiological responses. So this is really an important opportunity to try to create some new curriculum that will be shared with people in hospitals or in clinics who are working with pregnant women and young parents to try to help address implicit bias. So we think this is another important strategy in helping address some of those health inequities. Oh, I should also say, I'm sorry, I want to just go back. There's also some important data collection points that we will be able to track. The state is not tracking them right now around mortality. Some of the morbidity questions were up for debate, but we're really trying to better track both through publicly insured and privately insured families, how they are impacted and whether or not race has an impact on their health outcomes. And then I wanted to just name a couple important federal policy updates that we've been tracking that impact the families we serve. So we have, in Minnesota, we have federal funding for home visiting. It's called MICV. Well, it's actually every state who chooses to. It's the federal funding stream for home visiting. It's all evidence-based home visiting programs. There was additional money that went into home visiting through the federal funds. The way they wrote the regs, though, it really only impacts families who are served through that funding stream, which is really unfortunate. But that is how it was written. So it will provide additional resources to families that receive home visiting through that funding source. It allows families to get access to food cards, to diapers, to transportation costs for health visits. So there's some really nice, important flexibilities in how we serve families, but it's going to be a limited number of our families in Minnesota. I think it's like 160 families that will be impacted by this. I will get you that number for sure, but it's a smaller number than we'd like to see. And then you heard me say that the state extended the MA coverage postpartum 12 months. An important part of that equation is that in the American Rescue Plan, there is policy language that allows states to extend up to 12 months without CMS approval. So we generally need to get CMS approval when we do Medicaid changes. So this is up to 5 years. The state law that passed does not cap it at 5 years. It actually requires the commissioner to submit for approval to CMS that we change this. It is not meant to be a 5-year change. It is meant to be an ongoing change. And then there was $1 billion put forward in federal applications for Head Start and Early Head Start, which we also see strong evidence around reducing child maltreatment. So we are excited that that is part of the equations to help our families. There have been increases in WIC and SNAP allocations, and then there's been funding directed towards mental health, social emotional development, and early education for families. And this is a little bit older families, but I do think it's important to highlight because I know it will matter to all of you. There's been increased funding for school-based mental health services and school-based substance abuse. There is some new policy that will have alternative access points for residential children's mental health services. So for an older child who might be at risk of abuse. So there's been some really good strategies and focus points on mental health services for children. What we saw over the past school year is that, families access mental health services differently. Sometimes kids were less likely to engage in their mental health services through telehealth because families were listening in or they were worried that they could hear them. So we're excited to see how families move forward with this extended telehealth option where they can maybe pick and choose a little differently how they help support themselves. Okay, and that was it for my slides. That's part of the formal presentation.
Well, great. Thank you, Laura. That was a great overview. And usually what we do at this point is open it up for questions and comments and opinions. So, and I certainly always have some, but let me start out and see who else might want to jump in with questions. And you can also put them down in the chat box if you like. And you can also, if you like, if you don't mind, turn on your cameras at this point. It won't be as distracting. But so I'll just start out with one to get it going. You were talking about initially they made an $800,000 cut to the public health nursing component of this because you phrase in terms of a lack of flexibility. My layperson's understanding of that issue is, and maybe you can expand on a little bit, is that the limitations were kind of excluding some of the more not only innovative programs, but programs that actually were able to operate in communities of color or rural communities or other hard to reach places. And the nurse home visiting program, while it is the gold standard research-based model, isn't actually able to reach a lot of people, which is kind of, like if you can't reach them, you can't use the gold standard, right? And so wasn't there a little bit of a tug of war there? Is that what that was about?
Yeah, so I think two things. I'll speak to the 800,000 reduction first and then speak more broadly about eligibility, because I think that's an important thing to, I didn't know how much in the weeds you want me to go about home visiting. But I would love to go there with you. The $800,000 reduction was offered up because when we started this beginning of session, so, we usually get a November forecast, or excuse me, a December forecast for our budget. And then so we get a couple different forecasts of how our budget looks. When the governor put together his budget, the governor and his team put together his budget, we were looking at a budget shortfall. So he was looking to capture revenue through program cuts, and he offered up a number of tax increases. When we got the February forecast, so session is already started, the governor's budget is already out there, we now all of a sudden have a $1.6 billion surplus. So there's no reason to cut those programs, right? And now he has less leverage to try to increase, or reason to raise revenue through the tax increases. So part of this played out where they were looking for ways to find some savings, and because of how because of the way in which the language was written for the nurse family partnership, they have a separate allocation in Minnesota. They had really strict guidelines about it being the funding going only to expansion of nurse family partnership programs or startup. It wasn't to sustain the current programs. So it made it challenging to spend some of the resources. So there were some actual issues around how it got spent. But to the point you mentioned, or the point of your question, Rich, around eligibility, one of the challenges that we found with home visiting, with a model program specifically, so there are a number of different models that are out there, but each model sets its eligibility. So I think of eligibility as this box. If you fit within this box, if your life situation fits within this box, then we can offer you this program. And part of the eligibility requirements for nurse family partnership, which is the gold standard in home visiting, it's been the most evaluated program out there. It's a wonderful program, but you have to be a first-time parent, and you have to start the program by the time you're 28 weeks pregnant, which makes, so that limits a whole lot of people. And what you all know, working in child welfare, is that sometimes it's the second or the third pregnancy that really puts a family beyond their limits of being able to manage things alone. And then all of a sudden they find themselves in a situation where they are taking risks, and their family is not in the best situation. So you might see an increase in neglect, or you might see some child abuse at that situation. So it's not always something that happens in that first pregnancy. So there are a number of other models, though, that don't require you to be a first-time parent. And those home visiting programs then are different boxes in which people might be eligible for. And that's why we continue to say we want these innovative funds, funding for innovative programs who might change or create a new box. And to your question, the part of your question around reaching specific populations, we know that because of the high maternal high death rate in maternal health and infant health in our Black, and it's really about our African American community, or it's our American born African American community specifically. When they have an increased maternal and infant health. They have increased maternal and infant health rates. So, and then the Indigenous community. So those two communities specifically, we need to get better at finding programs that are trustworthy, that meet the needs of communities and their specific, that meet the needs of the communities, and honestly, that come from within the community themselves. A lot of times in Minnesota, when we test programs, because it's such a predominantly white state, we're not always reaching communities of color in the ways that we say we want to. And so we really want programs to come forward from within the community that they value, that they've seen successful. That was a long answer, but.
Well, it was, but that's what I was, wanting to get at. And I think, having been at some of your meetings, I think that there was, and I just want to give you credit for working this out, because there was some direct competition or even conflict between people who wanted to hold to the gold standard evidence-based models, and those who said, that doesn't work in some communities, and we have to be a little more flexible so that we can reach people. I think we've been working a little bit with the Hmong community, which is extremely wary of anybody from the, kind of established, outside network coming into their community. Same with, say, Somali Americans. So the point is you actually have to connect with people in order to offer the service. Also, the public health nurse model, we don't have that infrastructure in a lot of parts of the country or in a lot of parts of the state. So again, you can't deliver the service if you can't connect with folks. So what I wanted to give you credit for is, I don't think I mentioned at the outside, but you have over 70 nonprofit and organizations in your coalition. Now, I've worked with coalitions. They're extremely difficult to work with, especially when people don't just overlap, but they actually have different, and they have different goals that can be in conflict. So the fact that you've gotten this group this far is, really a major accomplishment. I just want to give you credit for that, because I've been in a lot of coalitions and very few of them have held up and held together long enough to pull off some of the things that you succeeded in. So I just wanted to make that point.
That is very generous, and it is definitely a partnership, and there are many of us working on it. So I will bring back that praise to my colleagues as well.
Yeah. But I think you were the key. Your patience exceeds mine, that's for sure. So again, I had another thing I wanted to throw in to, mix things up a little bit, but I want to stop and invite people again to ask questions. I haven't looked at the chat box lately. And or comments of your own experience that you want to share.
If not, I would love to talk a little bit about the infant and early childhood mental health work that we're doing, if you're so inclined.
Sure.
Okay, I just think it's relevant to the group as well. So we, the coalition in 2020 and then again in 21 did what we just call it the COVID survey to better assess how is home visit, like what's happening in the field of home visiting with the home visitors, the practice, and the families. What has been the impact of COVID? And in 2020, when we did the survey results, what we heard loud and clear is this concern among home visitors for the mental health of the parents and the children, and how just access to resources, access to services, and just the whole concept of the disease and not knowing what was okay, and all these mixed messages that people have been getting in different media sources. So they talked about that, and what we were able to do is work with our state Department of Health to identify some capacity building resources and make some training available on infant and early childhood mental health, and also consultation services. And what we would love to do is see as many people who work with families as possible get trained in infant and early childhood mental health consultation. Because we tend to do is when we talk about mental health, we think about it as a problem, right? Instead of a normal part of our development. And what we have been doing is working a lot with people to talk about the critical benchmarks that lay the foundation for one's emotional well-being, and how that is the foundation for one's mental health moving forward. So we've been doing some training this summer. It's been fascinating. I think the more professionals that we can get trained in on this, professionals or paraprofessionals, I would love to think about how do we get child protection workers trained in this. I know we don't always get to work in tandem with them. Sometimes it's a handoff. Sometimes some of the home visitors are working with child protection workers, but not always. I would love to see how we get more child protection workers trained.
And guardians ad litem and foster parents.
Oh, that's another, I'll add that to the list. Thank you.
Do you have any materials on that you can share, or is it we can stick up on the website and I'd like to read them?
Yeah, I will.
And we'll put this presentation, if you share it with us, Laura, on the website along with the recording. But if you can just send us your slides, that would be great.
Oh, sure.
Well, anybody interrupt me, but I have one other issue I was going to toss in, and I don't want to put you on the spot, Laura, but I think I'm going to put you on the spot by asking this question. But I know you can handle it. I had some concerns about the fact that substance abuse reporting requirements are, off the table, that you don't have to report. Mandated reporters don't have to report substance abuse. And, I've been in a number of your meetings, not recently, but I can kind of picture the people in the room. And I can't think of anybody who would say, well, wait a minute, what about the child? Because if you have a woman who is, say, seriously abusing alcohol, and you end up with someone with a baby with fetal alcohol syndrome or fetal alcohol effect, you really can't unring that bell. It's done. That child has a very limited life from that point forward.
Mhm.
The only thing that gives me any relief on my concern is that I've seen two studies, one done in Hennepin and one done in Ramsey. And Ramsey had a zero tolerance policy. If a woman was abusing, drugs, then she was reported to child protection. And in Hennepin was the opposite. And their evaluation showed almost the same outcomes. The problem is it's one evaluation. It's not a research study on each side, and there's not a lot of other stuff. So I just have some concerns. It seems like, many times agencies really relate to the parent and to the adult. They don't relate to the child. And that's who we have our connections with, is adults. We don't really have the connections with the child and the family. And so I'm concerned about how that conversation went. And I'm concerned about this being in the legislation, frankly.
Well, the legislation, I will go back and look at it again, but if I'm not mistaken, the legislation changes the requirement to be permissive. And the permission is only there if the mother or the individual is actively working on their substance use. So if you have concerns because they've stopped, then it would be reportable. But if there's actively working on addressing it, and we know, unfortunately, that substance abuse recovery often looks like you stop. We know that there's those intermittent periods. And so there was a big push to try to decriminalize some of these activities. I don't disagree with what you say is the impact on a child. What I do believe to be true is that I don't know that the outcome is that much different if we take the child away. I mean, it's
Right.
the amount of harm done to a child by moving into the child protection system is pretty significant as well. So
right. Well, it is not like the only option is to remove the child. First of all, the child's not born yet, but it's almost a question of who are we protecting?
Yeah.
Who are we concerned about protecting here? But anyway, I just wanted to, point that out. And as I said, you can't undo it if a child is. It may be one thing if they're born with some exposure to cocaine or more, manageable, but you can't manage fetal alcohol syndrome. It's done. So anyway, just wanted to stir the pot a little with that. So any other comments or questions?